Kia ora and good evening, everyone. My name is Amanda Rose and I'm the National Manager at Multiple Sclerosis New Zealand. On behalf of MS New Zealand and our colleagues at the New Zealand Multiple Sclerosis Research Trust, I have the pleasure of welcoming you to tonight's special webinar, marking World MS Day. So today is the day when all those impacted by MS are invited to come together, celebrate global solidarity and a hope for the future. For the past 4 years, World MS Day's theme has been connections, and MS Connections is all about building community connection, self-connection, and connections to quality care. I am thrilled to announce that today the MSNZ's advocacy work has actually just been acknowledged internationally as we've been awarded the UK's Oxford Health Policy Forum Team Award in the 2023 MS Brain Health Awards. We as an organisation are beyond excited to receive this international recognition for 8 years of campaigning to widen the DMT criteria, which is now seeing people start treatment on diagnosis and stay on until EDSS 6.5. This award really isn't just for us, it's for everyone who played their part in advocating for these changes, clinicians, people impacted by MS, our donors and our member organisations. And this award really reflects the power and value of collective voice. So we just wanted to say a huge thank you to everyone who is involved over the years for their contribution. As a relatively small organisation, 8 years of advocacy, I'm sure you can imagine, takes a lot of commitment, energy and resources. And we couldn't have done it without everyone's support. So thank you. And our advocacy obviously doesn't stop there. And AHSCT, as we will now lead into discussing, is another of our key priorities. So as we all know, AHSCT has captured the interest of patients and clinicians worldwide. Numerous New Zealanders with MS have travelled overseas to access AHSCT, and this has often meant undergoing intensive treatment in foreign countries, away from loved ones, and often with a huge financial cost in the range of between $70,000 and $200,000 in so many cases. But New Zealand is making headway towards it being made available here. As many of you know, in August last year, MSNZ was proud to present with our Esme Tombleson Award recipient, Joan Perry, the almost 11,000 strong petition signatures calling on the government to make AHSCT available. In November, we then presented with Joan to the Health Select Committee about the benefits of making AHSCT available from both a clinical evidence standpoint and a cost-benefit argument. And since then, Te Whātua has been undertaking their internal review, and we have continued our advocacy to them as well. We're aware that that review is still ongoing and that it's predominantly focused on resourcing. In the meantime, work was simultaneously underway by a team of New Zealand haematologists and neurologists to provide early access to AHSCT for select patients who would meet the proposed criteria. And we are extremely excited to welcome David today, New Zealand's first MS AHSCT patient, to share more with you about his experiences. Following David, we are fortunate to have Dr. Jennifer Pereira, clinical neurologist at Auckland City Hospital, who will share more about the proposed criteria and protocol. Neuro Physiotherapist Gilly Davy will talk around the recommended rehabilitation protocol. And lastly, by no means least, Dr. Zoe Dyer is joining us all the way from France. Zoe has been funded in part by the New Zealand Multiple Sclerosis Research Trust to join the groundbreaking team at St Vincent in Sydney. And for the last year, she's been undertaking exciting research into regulatory T cells in MS and how the body naturally stops autoimmunity. So we will take questions at the end of all of our speakers, apart from Dr. Pereira, who will have to take questions after her session. If you put questions into the chat function or the Q&A, we will cover these at the end of the session with the panel. The webinar is also being recorded, and we have a number of people who can't join us tonight, and it will be made available later on our website this week. So without any further ado, I will hand over to David. David is our first New Zealand MS HSCT patient and is going to tell you more about his experience. And yeah, thanks everyone.
Awesome. Thanks, Amanda. I'll just share my slides. Give me a second. Well, nice to be here this evening, everyone, and thanks for having me. I'm the one without the sort of doctor in front of my name on tonight's lineup, but I'm happy to be here to share my story as a patient with MS. from sort of my early diagnosis through to having a stem cell transplant here in New Zealand last year. So a little bit about me to kick things off. My name's David Linehan. I'm 35 years old. I live here in Auckland. I have 3 young kids, and I sort of work full-time in a finance-based role at the moment. I was diagnosed with MS back in 2014 with relapsing remitting MS. I was 27 at the time, and my first symptoms were numbness and sensory changes in my leg. I remember going for a swim at the beach, and my foot in the water was feeling like it was in hot water instead of cold ocean that it was in, and I knew something was up pretty quickly with that. My dad has MS, and so I knew a bit about the condition, and over a series of months and meeting with Dr. Jennifer, who we'll hear from this evening, we moved pretty quickly to a diagnosis of MS. Now, I was a reasonably young and active guy, and the biggest sort of symptom for me was the foot drop and weakness in my leg. And this was really apparent when I was running or sort of being active. I went on to fingolimod treatment pretty quickly after diagnosis at the end of 2014, and really looking back, was quite lucky to have been diagnosed at a stage in the treatment for MS that these drugs were all coming online. I think Pharmac had just approved fingolimod for MS a month or 2 before, and I was one of the first patients in New Zealand to go on that treatment. And that worked very well for a number of years. Over the last few years, the disease has progressed somewhat, and for me, that's sort of been quite apparent in that leg. That was the first few symptoms. So that weakness has progressed. I now sort of struggle to run, and my walking is impacted somewhat. So in 2020, we switched drugs to ocrelizumab, sort of higher efficacy, and hopefully sort of the idea there was to slow some of the progression and stop further relapses. And that was somewhat successful, but I did end up having another relapse on ocrelizumab. And really that kicked off the conversations and thinking around HSCT and whether that could be a pathway for me. So this wasn't a decision that I took lightly by any means. It was ongoing conversations with Dr. Pereira for a number of years. Eventually, we sort of decided it was getting to the stage where I might benefit from that, and was referred to Dr. Richard Ducey, a haematologist here in Auckland, to discuss the treatment and what's involved. And then I sort of went through quite an intensive research period for a number of months, talking with patients that had gone overseas to have stem cell transplant, talking with clinicians from around the world. And over a period of time, I sort of developed an understanding of the risks and the process involved. And for me, it became a trade-off of the known risks of the treatment. You know, it's a pretty serious treatment, and there are can be serious complications and even death in some cases. And it was a trade-off of that versus the unknown of how MS would continue to progress for me over my lifetime. And for me, that trade-off, I was willing to take that risk to hopefully sort of slow down the progression of this disease. So I then started looking at all sorts of options of where to get this done. So I spoke with some of Zoe's colleagues in St Vincent in Sydney in Australia, clinicians in the US and Singapore, Mexico and England, and spent lots of time trying to work out who would take an international patient, the costs involved, the protocols they use, and weighing up all that. And towards the middle of last year, I was all set to go to Singapore to have treatment done over there. But a few months before I left, I received a phone call from Dr. Richard Ducey, and this was all about the same time MS New Zealand had delivered the petition on the steps of Parliament around getting this treatment done here in New Zealand. And Richard Ducey said, listen, I think we can do this in New Zealand. I think you meet the criteria here, and I'd love you to be the first patient to get this done. So that was a huge relief for me. We were all set to do it in Singapore, but it would have been me going over there on my own at great expense and being away from family for what is quite a big deal of treatment. So with all that decided, sort of everything kicked into gear. So the transplant team in Auckland started their education, teaching me all about what the transplant treatment involved and what I was getting myself into. And then pretty quickly we moved into, sorry, I'll just get my slides working here. Here we go. Moved into the first step of treatment, which is mobilization. So they started me off on the first dose of chemotherapy and some other drugs to get my stem cells active and producing and out into my body. And then I went into the New Zealand blood service to get hooked up to a machine and harvested my stem cells for a couple of hours. So it involved some pretty big needles and some pretty strong drugs. And I ended up losing my hair, but after, you know, it wasn't too much of a big deal. That first step, it was a little bit painful and uncomfortable, but the first step was done. And this happened in September last year. Once they harvested my stem cells, then I sort of went back home and just waited for the treatment to begin and for me to get a confirmed spot at Auckland Hospital. So at the start of November, I got the confirmation that I'd be going into Auckland Hospital. So I moved into Motor Tapu ward on level 11 up at Auckland City Hospital. There you see actually a really nice ward as far as hospital wards go and a great view out over the harbour. And that was going to be my home for the next 3 weeks. So I started chemo straight away. I'd already lost my hair from the mobilisation a few weeks earlier, but this dose of chemo was a lot stronger, and I sort of felt the effects straight away. It was a bit of a funny feeling watching what you know is quite a toxic poison going into your body and knowing that it's going to damage your healthy cells, but sort of trusting the process. And luckily, I tolerated the chemo okay. I was very tired and fatigued, but didn't suffer from the nausea that lots of people get. They fill you up with all sorts of other fluids, and I was pretty much on an IV drip for 24 hours a day for that first week. And you can see in that photo on the right-hand side, I put on quite a lot of weight of all the sort of fluid in my body. After a few days of chemotherapy, they do the transplant. This is where the stem cells that were taken out of my bloodstream a few weeks prior, they reintroduce, and this is called day 0. So day 0 for me was November the 7th, 2022. The stem cells arrive in this big black tub that's all sort of cryogenically frozen and preserved, and they get them out and defrost them, and then hook them up to the drip and put them back in, and that's that bag of red blood cells you can see at the top of my drip while I'm in bed there. And it was all sort of built up to be quite a big experience for the treatment, but in all honesty, it was a bit of an anticlimactic event. The new stem cells went in, I didn't really feel any different, and it was all over in about 30 minutes. But the next few days and weeks after that chemotherapy, my immune system had bottomed out, and I was at basically 0 white blood cells. It was a real blur of sleeping and in and out of severe sort of fatigue and sleeping, and no energy to do anything. My wife and my parents could come visit me, but my kids were not allowed in there. We had to be really careful of infections at that point when you've got no immune system. The nurses were just amazing. They're so thorough around infection control and monitoring me. It's sort of constant temperature checks and blood pressure checks and blood tests to see what's happening in there. I had to have a few infusions. I did have an infection in that time when I was neutropenic or had no immune system, but thankfully I responded really well to the antibiotics, and it didn't turn into anything too serious. And so every day the nurses are taking bloods, and you're monitoring your red and white blood cells, and just waiting for the bone marrow to kick back in to action, those stem cells to get back into your bone marrow, for them to start working again and start producing new blood cells. And so every day I'd get the blood test results from the doctor that would come in and visit, and it would be flat. Some of the red cells were declining, so I'd need another infusion of red blood cells. And then on day 10 after my transplant, the cells started to pick back up, and that's the first sign that things are working. The stem cells are back in there doing what they're meant to be, and from there each day I started to feel stronger and less tired, and was able to concentrate again, and could start watching the hospital TV and listening to the radio, and just had energy again. And then after 3 weeks in hospital after that transplant, I was able to go home. So this is sort of me saying goodbye to the motor tapu ward that I'd been in there for 3 weeks, and while it was an awesome experience, in particular all the care and the nurses, I was very pleased to get out of there and pleased to see the back of hospital food in that one room and walking up and down the corridor. But I was still very tired, very weak, but still very, pale and looking pretty sick. You can see that photo on the right. That was me a couple of days out, going for a walk up down Hobson. But I was feeling good. I was positive to be out of there, and in particular, I sort of noticed some improvement straight away. So the mental clarity was noticeable from sort of day one. As soon as I got out of hospital, that brain fog that I'd just become accustomed to living with MS was the most noticeable and most significant, more or less, as soon as I received the treatment and was out of hospital. So over the course of those few weeks, I obviously lost all my hair. I lost lots of weight and lots of strength, and was pretty weak. But I was actually expecting a lot worse from my research and talking to others. And so I think I got off pretty lightly in the end, and largely because I didn't have any serious infection or complication from the treatment. So within a few weeks of getting discharged from hospital, I was able to see the kids again. My immune system, my white blood cells had got back up to a level that I was able to integrate back into the world. And so this was at the start of December, and I was able to sort of get back and enjoy a summer holiday with my family in particular. So, this was now, it's sort of 6 months post the transplant. I've had no new symptoms, and I'm now sort of drug-free. So I'm no longer taking that ocrelizumab or any of the other disease-modifying therapies. And the big focus for me is now rehab and getting some of the strength that I lost during the treatment back, and seeing if we can make some gains on the disability that I have. It's not a cure. It's not like my MS has gone away, but I do definitely feel different. And I feel, I think the mental clarity is the most obvious, but I do feel like some of the gains that I can make physically, hopefully, are things that don't slip away as they have in the past. So looking back on the whole experience and the treatment there at Auckland Hospital, I think firstly the team there were just amazing. While I was their first MS patient, they do this every day for cancer patients up there in the transplant ward. They're incredibly professional. They're so thorough, but they're also warm and confident, and I just can't speak highly enough of the nursing team and the doctors up there. My team, my neurologist and hematologist and physio, most of who are on the call and you'll hear from tonight, I'm just incredibly lucky to have such a good support crew around me. I was really lucky that I didn't have any complications going in. I think comparing myself to lots of the other patients in motor tapu ward, my recovery was a lot faster, and some of that is because I'm a bit younger and fitter and healthier than the cancer patients there. But I also was just lucky that I didn't have any complications while I had zero immune system. So it's been just over 6 months. I think it's too early to say whether it's worked or been a success, but so far so good for me. And success for me was always halting the disease as much as can be done and sort of stopping any new symptoms coming up. And so, and if I can do that without being on any drugs, for the rest of my life, or at least for a little while, I think that'll be a successful outcome. The hardest thing for me was being away from my family for that time and not seeing the kids. But that's what I did it all for. They're the motivation, and I'm just incredibly lucky that it all went well. So yeah, that's my story, and I'm happy to answer questions or at the end, and then and talk to people as well. Please feel free to reach out to me if you do want to discuss this in any more detail.
Thank you so much, David. It's always really interesting to hear your story. Obviously, I've followed it for a bit of time now, and it was great to catch up and learn a bit more about it one-on-one and hear more about it tonight. Thank you. As David says, we'll do questions at the end. I'm sure lots of people have lots of questions coming through, and feel free to put those into the chat or into the Q&A, and we will cover those at the end. Next up, I would like to invite Dr. Jennifer Pereira, who is actually David's neurologist. She is a clinical neurologist at Auckland Sea Hospital. And Jennifer is also employed at the University of Auckland, where she works as a senior lecturer in neurology. With a special interest in immune therapies and the treatment of multiple sclerosis, Jennifer has completed her training at Auckland and at the Therapeutic Immunology Group at the Department of Clinical Neurosciences in Cambridge in the UK. Jennifer is also the chair of the New Zealand Ahsct working group of New Zealand neurologists and haematologists, so has a very unique insight into the workings that is happening. We thought it's very important to make sure that people are understanding what the proposed protocol and the proposed criteria are looking to be. And Jennifer, are you able to share your video with us and join us?
I think you need to share my video because you stopped.
There we go.
Yay, thank you.
Perfect.
Yeah, and I'll just get my slides here. Okay, so hopefully you guys can see me and see my slides. And yeah, special thanks to David for talking about his journey, and it's nice to have been along for the whole ride as your neurologist, obviously, and it's certainly interesting in his particular case because it sort of spans the real treatment era of MS as it's been since that 2014 when we first got fingolimod, and that was great for us at the time to have treatments to start treatment early, and now we're sort of coming into the Ahsct era, and yeah, David's been a pioneer really. Definitely my first patient in New Zealand starting fingolimod. I'd had a few who'd had it in Australia, and then first New Zealand Ahsct person. So yeah, it's been a real journey, and certainly David's been a person of firsts. So yeah, interesting. The Ahsct has been something that it's been around for quite a while now, and I was looking back and seeing that we first organised as a group of MS neurologists to meet and come up with New Zealand criteria for patients that should be considered for Ahsct in 2018. We had some criteria. These have now been reviewed, and it's the 2022 selection criteria I'm just going to talk through today. I still remember prior to 2018 talking to your neurologist about Ahsct was something that patients always sort of felt a bit worried to do because it wasn't really an accepted treatment, and there was a lot of sort of uncertainty around it. But over time now, we do have things that we feel pretty confident and have a good understanding about in terms of where Ahsct fits. but there is a lot of unknown, and that's why it's been so helpful having Zoe going and being with the team in St Vincent's, and there's a lot of research. So what I'm presenting to you today is criteria based on what's known in 2022, 2023. These were written last year. And that doesn't mean that they're stamped in stone. It certainly doesn't mean that they won't change, because even in the 4 years from 2018 to 2022, there were a lot of changes. These criteria were formulated and agreed upon by the New Zealand AHSCT committee for MS, and this is a group of neurologists. So we do consult with haematologists, but this is purely from a neurological point of view. Who is it that as MS specialists treating patients with MS, who do we think should be put forward for an AHSCT as they're likely to benefit from it? So it's based on expert clinical opinion, the results of the phase 3 trial we've got and other published evidence. And it's also, particularly the 2022 criteria, were based around what other centres, in particular St Vincent's, what criteria are they using when they select patients for AHSCT. These criteria were agreed upon by the group of MS specialists, but then also presented to the Neurological Association of New Zealand meeting in 2022. So the neurologists in New Zealand have also been presented these and had a chance to discuss them before they were sort of formally accepted as current criteria. This is the criteria, have a couple of paragraphs to start with, so I'll just read these because they're quite, they make the criteria sort of make sense. So there is emerging evidence that immunoablative therapy followed by AHSCT may be efficacious in treatment refractory relapsing MS. Most studies evaluating AHSCT are open label, single arm trials, and the AHSCT procedure is not uniform across studies. There's been a single phase 3 trial of AHSCT versus disease modifying therapy, showing that AHSCT may slow disease activity and disability progression for people with MS who have not responded to DMTs. Following a critical review of the current evidence for AHSCT and MS by a working group of MS neurologists, we propose the following patient selection criteria for consideration of AHSCT for MS in New Zealand. So these are the criteria. So there is an age criteria. That's definitely not sort of, again, not set in stone, but that's just to give guidance to treating neurologists about what age is probably the most appropriate. The age is not really based on the person's age itself, but it's more in terms of when is MS, in terms of the person's lifespan, most likely to respond best to AHSCT in terms of being most immunologically active. It's also reflective of like David alluded to, the risk of having other comorbidities that might impact on the safety of having an AHSCT. So it's the age is definitely a sort of more of a advised rather than an absolute. Again, the disease duration, so this is also based on, when is MS most likely to be inflammatory, most likely to respond to AHSCT as an immunotherapy. So disease duration, 15 years from first clinical event. Then this next one is around the requirement for patients to be on a treatment of their MS and have failed an effective MS treatment prior to them then being eligible for AHSCT. And this is because at the moment AHSCT for MS is a treatment for those who have medically refractory disease. So that means your MS is not controlled by the current available therapies. So how do you define that? So patients need to have active MS, which is at least one clinical relapse, despite being on a high efficacy treatment, which based on these criteria includes natalizumab, ocrelizumab, ofatumumab, which we don't have in New Zealand, alemtuzumab, fingolimod, and cladribine. So patients on high efficacy treatment for more than 6 months, or where no such treatment is possible. So if you're someone who's unable to tolerate those treatments, or for some reason not eligible for particular treatments, if you have active multiple sclerosis, it could still be that AHSCT would be considered for you. And you also need to have evidence that not only are you having a relapse clinically, but you need to have evidence on MRI imaging that your disease is active. So a relapse event and evidence of a new lesion, so a new T1 lesion, a new T2 or flare lesion, or a contrast enhancing lesion that is new and did not happen in the time leading up to your high efficacy therapy. So it needs to be something that has occurred while you're on treatment for a decent amount of time. And from a disability point of view, similar to the treatment pharmac criteria, so between 0 and 6. But if you have very recent onset disease and some of the disability may be inflammatory, then a higher disability level could be considered if you have a shorter disease duration. So if you were to meet that criteria, what happens? So if you see your neurologist and talk through your history and recent relapses and MRI results and the drug you're on, and between the two of you, you think, well, I actually do meet criteria to have an AHSCT. The next step that's agreed upon as part of these selection criteria is that as a group, there's a group of MS specialists who will consider your particular case. So again, review the history, your clinical exam findings, what treatments you've been on, what your MRI scan shows, and then agree with your neurologist or explain to them what it is that means that you don't meet the criteria. And then that group would determine if, in your particular case, the AHSCT is indicated. And that's indicated from a neurological point of view. So we're deciding as the MS specialist whether or not an AHSCT is the right thing for your MS. So if the MS specialist group agree that an AHSCT is appropriate for your particular case, then the next step is an assessment by a haematologist. So it's worth looking at and thinking about it as two quite distinct kind of branches: the neurology requirements and then a haematologist. So a haematologist would not decide whether an AHSCT is appropriate for your MS. They would then decide whether an AHSCT is safe for you to undertake. So safe and appropriate from a hematological point of view. So those are two very different things. So your neurologist might not know whether an AHSCT is safe for you, but a hematologist would, and a hematologist wouldn't be expected to decide whether an AHSCT was appropriate for the treatment of your multiple sclerosis. So important points around the selection criteria is the biggest challenge is to determine whether, in fact, your MS treatment has failed. So this is something that your neurologist may need to consult an MS specialist to help them to decide. The main challenges are from a radiological point of view, comparing an MRI scans to a true baseline. So, for example, if you were on beta interferon and then you decided, and your MS was relapsing on beta interferon, and you switched to natalizumab, in order to know whether the natalizumab was effective, you'd need to do a new baseline scan a couple of months after starting natalizumab, and then if you had a new lesion on the baseline scan, that wouldn't be treatment failure. That wouldn't be that the natalizumab was working. You'd need to wait another good 6 months and then compare back. And most people don't have any new lesions on natalizumab. Where you see new lesions sometimes is if you're still getting disease breakthrough from the lower efficacy treatment coming through, because you're not comparing to a true baseline scan. Most people on the high efficacy treatments do really well, and their disease is controlled without needing to be exposed to the risk of an AHSCT. The main risk, obviously, that we're worried about is the mortality risk, but that can be quite low. So like David explained, the treatment itself, there are lots of potential for things to go badly, including sometimes people do die as a consequence of the AHSCT because your immune system is so reduced. But for most people, it's a challenging process, but you know, it's successful in terms of not too much morbidity, but it's important, obviously, weighing up what's the risk of the treatment. So what's the risk of an AHSCT versus the risk of natalizumab, for example. The other important point is that obviously the selection criteria that we have currently are based on the data we had available in 2022. And there's certainly changes and results of clinical trials coming up, which means that it's important, and we know that the criteria needs to be under review, and there are certainly more and more trials coming through. There are trials recruiting currently where the outcomes are going to really have a big impact on how we view this and what the selection criteria are. And the main two clinical trials that will be particularly interesting are the Beat MS and Star MS. There are another few as well. I think there might be 5 or so going, recruiting at the moment. These are interestingly reasonably similar to what our current criteria are. So in the Beat MS study, it's a randomized control trial of AHSCT versus high efficacy treatment. You need to, in order to be included in this trial, which is running in America, and either America and the UK or just America, I'm not sure, you need to have one event on a DMT, and you can either have had 2 relapses or 1 relapse and evidence of disease activity on the scan. The Star MS trial is, again, a trial of AHSCT versus high efficacy treatment. And in order to enter into this, the patient needs to have had 2 or more relapses, or 1 relapse with MRI activity at a separate time point in the preceding 12 months. So looking at patients with relapsing remitting MS with relapses and evidence of MS disease activity. So that's the criteria, and yeah, I'm happy to answer any questions you guys might have.
Thank you, Jennifer. That was really interesting. We have had one question come through. People feel free to type your questions again into the chat or into the Q&A, and we can ask from here. We've got our first question around this is AHSCT appropriate for primary progressive MS?
So at the moment, we don't think that it is. There's not been a trial of for patients who have primary progressive MS. These trials that we're talking about with the Beat MS and the Star MS trial and the MSNZ study were all randomized controlled. They're all randomized controlled trials of people who have active relapsing remitting MS. So there isn't any trial data to support the use of AHSCT for those who have primary progressive MS.
Thank you. Second question that's come through, are there any trials and/or provision of umbilical cord MSc in New Zealand? I understand it has a higher success rate and is less invasive with less side effects, etc.
Yeah, so the umbilical cord stem cells is a very different process than the AHSCT, and also probably, depending on what you're using it for, has a different certainly a different mechanism of action. So it's worth thinking about those types of stem cells are very different from an AHSCT. So when you're having an AHSCT, it's that you're annihilating your immune system. So you saw heard from David and saw what he went through. So it's getting rid of the immune system and then allowing the immune system to regrow in a way that the immune system is re-educated and is less immune active. So Zoe will likely present some research that shows how the immune system's different after an AHSCT compared to before in people who have MS. So it's very different from the umbilical cord or mesenchymal stem cells, where you're putting some stem cells into the system, and those you're using the stem cells to either promote repair or to shift the way the immune system's functioning. But it's very different from re-educating the immune system for people who have MS.
And next question that's come through, does AHSCT get rid of MS completely?
So kind of, but not really. The AHSCT is an immunological treatment for multiple sclerosis. So it's similar to our current medicines. So when you're on natalizumab or ocrelizumab, you're on a powerful immune treatment, and mostly with AHSCT, with natalizumab and with ocrelizumab, your immune system is treated in a way that you're not getting any new MS disease, so you're not getting any new lesions formed, but it doesn't get rid of your MS. So like David was saying, he still has damage from the multiple sclerosis lesions that he has from before, so he needs to rehabilitate and get as strong as he can to recover, and that the AHSCT itself will not does not heal MS damage. Hopefully what it does is allow the body to heal better itself, because the immune system is now behaving in a much better way. There's less inflammation around, and yeah, hopefully you can allow healing, but the AHSCT itself does not do that.
Was David's AHSCT part of a trial in New Zealand, or why was he able to have it done here?
So he was not part of a trial in New Zealand. We don't have a clinical trial. We don't have any trials running in New Zealand for AHSCT. So David and any patient who meets the current, even going back to 2018, when we had the old selection criteria and now the 2022 criteria. So if your MS meets neurology selection criteria for an AHSCT, then the haematologist will consider it as per the steps that we went through before. Let me just put... for some reason my slides have frozen. Oh yeah. So if your MS meets the New Zealand criteria for AHSCT, then you can be considered for an AHSCT we don't have a trial running here, so that would be done through your neurologist.
Great. If you came off a high efficacy DMT and then relapsed with a new evidence of MRI before going on to another DMT, would that qualify you, or do you need to have it while on medication, i.e., if you came off natalizumab, then due to becoming JCV positive, then relapsed before starting ocrelizumab, would that qualify you?
Probably not. Probably not. So the idea, the whole reasoning behind the criteria is that your MS fails AHSCT, fails high efficacy treatment. So that's not really a treatment failure. That's more that you didn't have any treatment, you didn't have treatment, and therefore your disease broke through not being on treatment. The natalizumab, we know that natalizumab only lasts in your system up to 8 to 10 weeks. So if you relapsed when you were transitioning, that would be a bit unusual. So usually we put ocrelizumab directly after natalizumab, so you don't have a period of time where you're at risk of relapsing. It would be worth speaking with your neurologist, because it might be that in your particular case that there's something about the process that means that you are eligible. But I think if you had a relapse and you were off natalizumab and you hadn't yet started ocrelizumab, then probably not. But definitely worth asking your neurologist, because specific to you.
Is AHSCT almost like resetting your immune system?
Yeah, exactly like that. So it takes out your entire immune system, and your immune system regrows from your own stem cells. So you still have, it's from your stem cells rather than getting the stem cells from other people. But it resets the immune system. That's exactly how it works. Yeah.
Has Pharmac okayed use of AHSCT in New Zealand? It obviously actually isn't Pharmac who need to okay the use, but can I rephrase that too? Has Te Whatuora okayed the use?
Not that I know. I don't think there's any pot of money set aside specifically for AHSCT. So there's not a pot of gold there for people who have MS waiting for an AHSCT. It's more that, and that would be ideal. The difficulty is with AHSCT is, like you mentioned earlier, it's resourcing. Mm-hmm. So currently there's too many patients already who have hematological malignancies or other reasons for accessing AHSCT. And so the better Te Whatuora can resource the hematologist and their HSCT provision, that will mean that if you have MS and you meet criteria and you need an HSCT, then it's more likely you will get it in an expedited way. But at the moment, what the neurologists are saying, and the hematologists as a group have also met and agreed to this, that AHSCT is a recognised treatment for patients with multiple sclerosis who have active disease on treatment, and that they should therefore be referred to hematology and be considered for an HSCT. So it's not that there's a specific pot of gold or money for patients who have MS who need an HSCT, but yeah,
it's just that at the moment it might limit the availability of how many people can access it based on what the availability of the services is to keep it.
Yeah, it's more a service provision. It's more a service provision thing. And it's different from Pharmac, because Pharmac fund the drugs, so it's an independent phenomenon to Pharmac as such, like you said, Amanda.
Yeah. Have you seen improvement in your own clients who went overseas to get AHSCT? And if so, what changed for them?
Yeah, I mean, it's interesting because we do have quite a few patients who've been to different parts of the world. It used to be mostly Russia, but certainly people who've been to India, Singapore, Mexico. And yeah, I mean, it's very much an individual thing, and different people have been for different reasons. So some people go very early in their disease, you know, as part of like, they just want to have it as soon as possible. Obviously, that's not at all what's recognised in the medical literature. Some people have it when they have primary progressive or secondary progressive MS. So the expectations for each person is quite different. I think the thing that I've certainly found from talking to people is similar to what David mentioned as well, is the brain fog seems to be a very early symptom that people notice does improve directly after the HSCT. Be interesting to hear whether Zoe's had that experience with the people that she's come across from St Vincent.
We have got the questions coming in fast, so we might just run over a little bit, if that's okay to keep going. Yeah. Is there treatment repair to the myelin sheath after HSCT?
Likely only from your own body's ability to heal. So with the reduction in the immune attack and less inflammation, then that allows natural healing. But the AHSCT itself probably doesn't in and of itself heal, but it allows the body to heal.
Great. How do you do you need to have finished having a family to have this treatment if you want one?
So you can get depending on the different drugs that are used, but certainly you'd want to ideally finish having your family, or some people do have like eggs harvested and things like that. So important consideration when you're having the level of chemotherapy that's required.
Yeah. How can you ensure the stem cells taken are clean and not infected?
Yeah, so they do have processes to make sure that what goes back in is safe. So there's definitely wouldn't be any viruses in there, and different things are done to the harvested stem cells to make sure that when they go back in, they're as kind of clean as they can be.
Yeah. If you meet the New Zealand criteria, do you have to pay private? And a following question is, how much is AHSCT if it isn't funded?
So in New Zealand, there's no private AHSCT, so you can only ever access AHSCT publicly in New Zealand. So if you meet criteria for an AHSCT in New Zealand, it would have to be then funded publicly. There would be no other way of accessing it. So you'd see your neurologist in the public system. There's a system that then goes through to the MS neurologist considering your case. That would all be done in the public system. You'd then be, if your neurologist and the MS committee thought that you met the criteria, then you'd be referred through to haematology, all in the public system.
Yeah. If someone is currently on fingolimod but has active MS on their MRI and is switching to ocrelizumab, if that fails to control their MS, would that be a case which might be considered for AHSCT?
Yeah, definitely. So even now, if you fail fingolimod with a relapse and activity, then you would potentially be eligible for an AHSCT based on our criteria. If you haven't had a relapse but you've had MRI activity, then Ocrevus is definitely the next best step. And then on ocrelizumab, if you continue to have MRI activity and you have a relapse, then you would definitely meet the criteria. Yeah.
And what happens if you fall outside of that 15 years and meet the rest of the criteria? Is that one flexible that you could still be under consideration?
Yeah, I mean, I think the ones that are flexible definitely would be the age and the disease duration. The 3 and 4 probably are less because, I mean, 0 to 6 is pretty lenient. That's pretty good. It's more just what the HSCT is going to help is if your immune system is still active despite high efficacy treatment. And active despite high efficacy treatment is relapses and MRI activity. So you pretty much have to have active disease. But if your disease is still active and you've had MS for 17 years, then I do think it's worth having this considered. Yeah.
And how can patients find out if they are eligible?
So how you would be eligible is to, if you yourself know that you've had a relapse and you know that you've got activity on your scan and you're on a high efficacy treatment, so you're on natalizumab, ocrelizumab, or fingolimod, then the best thing to do is speak with either the MS nurse or your neurologist and say, I think I meet the New Zealand criteria for AHSCT and I would really like to be considered for this. And can you look at my case specifically with the criteria in mind? And, you know, Dr. Pereira's got the criteria. You can always email here and get the criteria. So if you think you meet the criteria, then the best thing to do is to meet with your neurologist and get them to check with you your history, your exam, your MRI scans. And then if they agree with your sense of things, then they'll then refer your case to the MS specialist committee that we have. So there's about 5 or 6 MS neurologists who would then again consider it from a neurological point of view. Does your condition meet our criteria? And then if so, we would then suggest to your neurologist to refer you through to the haematologist.
Great. And just the last 2 which have come through. What about those who are allergic to DMTs? Would they be considered potentially under that where no such treatment is possible?
Yeah, I mean, that's definitely possible. So you'd have to have evidence of active disease and clear-cut kind of the allergy/intolerance. That would be quite difficult to decide upon. But if that is your situation and you would want to have an AHSCT for your MS, then as long as you have active disease, so you've had a relapse and you've had on your scan there's still things happening, then again have a talk to your neurologist and say, my disease is still active, I'm still relapsing, I've still got MRI activity, and I can't have any of these treatments because of what's happened in the past. And then they would then again it would go through the same set of reviews by MS committee. And then if the MS neurologist thought, yes, this is reasonable for this person, they can't have natalizumab because their JCV, they were already on it for 10 years and their JCV is very high, and then this is what happened with Ocrelizumab. So it's definitely possible. It just would have to be considered like case by case and considered by that your neurologist first, and then the MS committee second.
Yeah. And if you have another autoimmune disorder such as Crohn's disease, would this potentially impact your ability to access AHSCT?
That would probably be determined really by the haematologist. Like as long as it was under control and not active, and the haematologists were happy that your gut health was safe for you to have a AHSCT. It wouldn't be something that would necessarily preclude it, to my knowledge. Zoe, that you could check in with Zoe because she's been more involved with the process from a haematology side of things. But from a neurological point of view, as long as there wasn't something, you didn't have a condition that clearly was active and dangerous to undergo an HCT, the neurologist would always check that question with the haematologist.
Right. And Zoe said she can talk about that later.
Perfect, thanks, Zoe.
And just the very last question, otherwise we'll never get to move on. They're coming through thick and fast. Back on the line of the umbilical cord MSC, is it available in New Zealand? And if someone didn't meet the criteria for AHSCT, would it be something to consider in the future?
So that treatment is completely different. So it's not related to AHSCT at all. So it's an unproven treatment of MS that's very different from AHSCT.
And I don't believe it is available here in New Zealand.
No, I think you might, not with umbilical cord, but there are some places where you can get other forms of stem cell injected.
Yeah.
You've got to.
But they're not evidence-based for.
Yeah, and it's not a treatment for relapsing remitting MS or progressive MS that is proven to be effective. So, yeah.
Thank you very much. Thank you so much, Jennifer. It's been very insightful, and hopefully we were able to answer people's questions here. I will just bring Gilly Davy also into the conversation. Hi, Gilly.
Hi, Amanda.
Hi. Thank you so much. Many of you obviously know Gilly, a neuro physiotherapist in Auckland, and she is currently practicing out of rope and neuro rehabilitation. Gilly has been involved with David's rehabilitation since he left hospital following his AHSCT, and has helped to develop a rehabilitation recommended protocol following. So I will hand over to Gilly. Thank you so much.
Awesome. Thank you, Amanda. And thank you very much for the opportunity to come and speak about what is a very exciting development in the treatment of MS. And just to clarify that David has actually been working very hard in rehab prior to starting HSCT. So though I've been involved with him for a number of years now. And that is what I'm going to really talk about today, because this is also something that is brand new to New Zealand. David's been the first individual to go through it, but it is still quite a new treatment still around the world, though people have been leaving New Zealand and accessing it for the last, 5-10 years maybe, but it is still relatively new. So there isn't that much research, as Jennifer was saying, hard research out there about all the pros and the cons and the criterias, but also the role of rehabilitation is just coming up. And hopefully this will, any of you who are interested in going down the line of AHSCT, hopefully this next 20 minutes will really help to understand what else you need to be doing alongside that treatment. So as Amanda said, I am a clinical neurophysio. I'm also the founder of MSNZ Head Start. So to start with, rehabilitation and exercise is essential for multiple sclerosis, full stop. So at whatever disease, trajectory you are on, newly diagnosed, right down to have had it for years. And it's also essential whether you are relapsing, remitting, primary progressive or secondary progressive. So it is essential for everyone. It is really essential before you undergo any form of HSCT, and it is absolutely essential to do it afterwards. And I believe this is probably where, Jennifer may have agreed with some of this, that those people who have gone to go and complete this overseas, this is where some people may not have achieved the best outcomes they could have done because they haven't had the intensity of rehab before, and they pretty much definitely haven't had the intensity of rehab afterwards, because the overseas options often don't provide this type of rehab, and they also haven't necessarily been encouraging how beneficial it is until we're kind of getting on later in this research. So just really quickly, just as the foundation, that it is remembering that exercise has been shown now to be neuroprotective. So we're not saying that exercise can cure MS, but we are saying that a strong exercise participation does have an effect at slowing down the progression of MS. It has been shown to reduce relapse rates by up to 27%. Someone asked earlier about, does HSCT remyelinate? And as Jennifer said, no, but hopefully it gives your body the opportunity to naturally remyelinate. It's really important to understand that exercise, and specific exercise, is what drives remyelination. So if you want that opportunity to get as much benefit from your HSCT, it is also about really participating in a really purposeful rehab program afterwards. It also reduces inflammatory levels. As I mentioned, exercise reduces relapse rates, and it improves multiple MS symptoms. There has been some really accurate guidelines on exercise intensity and dosage for each stage of the expanded disability severity scale. So Jennifer was talking earlier that those between 0 to 6 often fit the criteria here in New Zealand. So you can find out at what point along that scale, and also for those of you who are watching who are past the point, who passed 6. So this so you can, a copy of my slides will be available on the website via Amanda. So that article has got all the details you need to know, and that's a relatively recent article. And what it also talks about is the need to access an experienced therapist, okay, experienced health professional in MS. So as I mentioned, the protocols around rehabilitation, around what is needed and what is going to be most beneficial to to go alongside AHSCT is pretty new stuff. So this is the main paper. So anyone who is really interested in looking into this further, I would again strongly recommend reading this paper. This is one of the papers that I had emailed. Oh, sorry, something's just come up. This is one of the papers that I have emailed David in the past for him to have a look at. So when we're talking about pulling it all together, that we've obviously had lots of information from our fabulous neurologist and our hematologist, but it's also just often we would talk about looking at this as a biopsychosocial model of we're really looking at HSCT to optimize health and function, physical, cognitive, psychological, and social. There is unfortunately a real myriad of complications that can happen with AHSCT. So, and some of those are, obviously both David and Jennifer mentioned death, and obviously that's a pretty severe complication. But if we just go back a bit, the HSCT could be really beneficial for the MS disease process, but the other complications of going through such a severe round of chemotherapy can leave you quite cardiovascularly impaired. So being impaired from a cardiopulmonary capacity can put you at increased risk of other health conditions, things like diabetes, heart attacks, strokes. It can also cause what we call steroid myopathy. Okay, so that is basically the steroids damaging the muscles, but also sarcopenia, which is increased loss of muscle tissue. And David touched on that, how much strength he felt he lost going through the process. Can also cause chronic fatigue. So though lots of people talk about that brain fog and fatigue being improved, HSCT in itself can actually cause chronic fatigue. There's a risk of bleedings, infections, graft versus host disease, and importantly, avascular necrosis. So this is a lack of blood supply to a joint. I have had quite a lot of clients I've personally worked with who have access to HSCT for probably the last 8 years or so overseas. And I have had a couple of clients who have struggled with acquiring avascular necrosis in the hip joint afterwards. So those criteria that Jennifer went through, it is also been really shown that those criteria work for the person who's going to have the least amount of complications afterwards. So, that's also why they're there, for that success, not only from is it going to work, but also are those secondary complications there. When we're looking at the team, and obviously the team's been briefly mentioned by David and Jennifer already, but it's actually really extensive. So I did think I'd list the whole amount of team that could be there, because it's making sure that you've got all of these connections and people in place that, if any of this things happen regarding if you ended up with a lot of pain issues or infection issues, of who are all those people that can help monitor that. And we've got obviously, those specialist therapists and we have different therapists in, the health model that are going to see you acutely to subacute community-based. And this is not only physios, but occupational physiotherapists, speech and language therapists as well. So how does it all work? So rehabilitation, okay? So this is the rehab that is basically going to be delivered through 4 distinct phases of going through Ahsct. And what happens before the transplant? Okay, so 6 months prior, you need to be at least starting a rehab process. And I'm going to talk about each 4 stages in depth as we go. But this is where initial assessments are done, baseline measures, and getting you as fit and strong as possible. Okay, when we go into acute rehabilitation, so this is what's going to happen between weeks 0 to 4 of that transplant and isolation. So exactly which therapists are going to be involved, repeat of outcome measures, and what acute rehabilitation you will need in those first 4 weeks. Then we've got your subacute rehabilitation, so weeks 8 to 12. Okay, so this is where, again, where we're repeating outcome measures and really starting to get those rehab processes up and running. So David participated in a pretty intensive 8-week program after he was, all kind of medically stable, and after Christmas, and he'd had his break with his family, and then he participated in a really structured program then. And he's had a couple of months off, and then we're just about to start on another really big program, which is this community rehabilitation. So again, more outcome measures and really looking at that return to life. So these are the 4 processes of the protocol that we're putting in place. So as I say, because David's been the first to go through it in New Zealand, obviously it's our role as health professionals to try and get all these protocols in place for those who are going to be following in his footsteps, so that the whole rehab team knows exactly what is going to be required from who at which stage. So in this prehabilitation, so because I know that we'll have individuals who are watching this who do have MS, but we'll also hopefully have a bunch of health professionals as well. So those who are familiar with these, and some of you may not be, but these are a bunch of the outcome measures that we would want to be measured, okay, early on. So ideally 6 months prior to even starting your HSCT, and ideally even prior to that. So you've got your physical measures, we've got walk tests, we've got balance tests, 9-hole peg test is a hand dexterity test, grip strength, we've got leg strength with sit to stand, and a timed up and go is a stand up, walk around a cone and come and sit back down. There's also a bunch of self-assessment measures, so fatigue severity, we've got how you feel your walking's been affected by your MS and also quality of life, as well as cognitive screening as well. So these are all the measures that ideally, and it might not be all of these, but a good number of these measures should be taken, as I say, prior to even starting the rehab phases, but these would be the measures that would be repeated, okay, throughout all of those times. So at the end of each stage, you'll have these measures repeated. So what's going to happen in the prehabilitation? Okay, so ideally it's an intensive package. Okay, you're about to undergo a really quite a destructive thing on your body, and David mentioned about sitting there and looking at this bag of chemicals that is going to be going through your body. You want your body to be as fit and as strong, and then you want to be as well as you possibly can before going through with something like HSCT. So really enhancing your neuromuscular system and your respiratory system. Okay, chemo can have a real effect on, chests and that breathing capacity. So really making sure, you're as fit as possible, and you've reduced any risk of secondary complications, range of movement, spasticity, everything's really been done. So we want that pre-transplant fitness will improve outcomes. So the free kind of research papers that cover this topic at the moment all strongly point to the fact that the fitter you are before HSCT, the better outcomes you will have. And I can't stress that enough. So where some of that research is fitting at the moment is that you should be doing at least 30 minutes of cardiovascular exercise every day, strength training a minimum of twice a week. Again, really working on respiratory function, but also ensuring your nutrition, okay, and your stress management and general well-being is really optimized, as well as needing any cognitive rehabilitation as well. So if you've noticed any cognitive changes, this is the time to really amp them up as well. It's been recommended that high impact weight bearing exercises such as hopping, jumping and combination exercises should be really considered in this early stage as well to improve the impact on bone density. Now, there'll be some of you here who obviously participating in the hopping, jumping and skipping isn't possible, but this is work that we did do with David quite extensively prior to leading up to the HSCT, was a lot of what we call ballistic or power-based exercises. So often this intensive package, as I say, it's to optimize you to be in the best possible position to get the best possible outcomes from that medication. So then moving into the acute rehab phase. So this is from week 0 to 4. So this is when you've had that awful, really high dose of chemo and you're going to the point where they're going to start putting stem cells back in, okay? So the first thing we need to do is prevent secondary problems for gentle mobilization. So as David explained, that you tend not to leave the room, okay, from a infection risk. So you can't really go very far, which is good because we don't want you overdoing anything. So this is where you just be following a gentle stretch program and optimizing respiratory function. So you should have a respiratory physio coming in to check, okay, that respiratory function is good and there's been no compromises there. Okay, so as I say, the main consideration at the moment is the individual's immunity. And there is also this contraindication of, I can't quite pronounce the word properly as well as it could be, but thrombocytopenia, which is a contraindication for exercise. So this is about your platelets counts. So it's been shown that if your platelets count are below that, that's 20, I think it's millisomething per litre, is actually a contraindication to exercise. And then you'll see those platelet levels in that table below. It will show you when you can start with some gentle non-resistance exercise. I think David mentioned that some of the first things he did was just starting some gentle walking around and slowly built that up. And it wasn't until his platelet levels were stable, okay, that he could then start with some strength training with minimal resistance and then gradually building that up. So this is really important that anyone obviously going through this and the health professionals working alongside you during this phase of 0 to 4 and after that, that your platelet levels are being strongly monitored. Okay, so you know when it is actually safe to participate again in exercise. But ultimately, the main plan in the acute rehab is maintaining good respiratory function, okay, and also ensuring that there is you're just keeping joints nice and mobile. So it's often where we'll do things about manual handling advice, if transfers become an issue, any seating and posture advice. As David said, you're in a room for a long time, often feeling not very good. So there's a lot of lying around. So we don't want to cause any acquired issues regarding back problems or shoulder problems from, sleeping in funny positions. So the multidisciplinary team that should be coming in assessing and checking this is looking at the posture and the mobility, checking respiratory, but also looking at things like swallow and communication. So this would be your speech and language therapist to make sure that none of that has been affected, and also just checking that your cognitive function is still tootling along. So a stretching program in place, okay, and as I say, ideally a patient should be checked by a respiratory physio on a daily basis. So subacute, so that's moving then into from week 4 to 12. So this is generally when someone is starting to be discharged, going either back home or back somewhere again where they can be in a safe environment because the immune system is still highly compromised. So this is once they're medically stable. So this is when that those platelet levels are back up, medically stable. So this is when someone can start with that another period of intensive rehabilitation to optimize fitness, independence, and outcomes of that transplant. So this will start kicking in at about 8 weeks post-transplant. So normally that point between 4 to 8 weeks, we're just encouraging people to get out, get walking, get some fresh air, and just start just gently getting that body moving. And then from about 8 weeks, depending on where they are sitting, because obviously everyone responds quite differently at times, that's when we'll be starting to ramp up the exercise input. So this is where we need to be quite aware of the late effects of AHSCT. So this is therapists. So this is looking at those risks about bleeding, risks about infection. I've talked about the avascular necrosis, okay, graft versus host disease. So therapists need to be aware if things are coming up, because often as a physio, I might be doing quite a lot of intensive work, seeing a patient 2, 3, 4 times a week maybe. So I might pick something up earlier than, let's say, their routine follow-up with the haematologist or nurse specialist. So often it's the therapist's role to be really aware. So if anything crops up that is a slight concern, we can get these patients back to hematologists, neurologists, whoever it might be, to make sure that there isn't any significant side effects coming on at a later stage. So rehab here is also to really focus on that neurological presentation as well as cardiovascular fitness and strength. So again, back to that question about promoting remyelination. Okay, so if we want to try and improve any of that neurological damage, this is where a very structured, individualized rehab program is going to be needed for you. And this is where ultimately we're looking at self-management, okay, getting someone right up so that they can do this themselves. In an ideal world, I don't think this is going to happen under our Ministry of Health funding, unfortunately. So this is where there's potentially a few discrepancies with looking at the current delivery of HSCT under Te Whatu Ora, that the prehab and the subacute to later stage rehab is probably not going to be funded at this stage, but that's obviously an area that we can look to work towards. Overseas, who are delivering a really strong combination of rehab and HSCT together and getting the best results. So over, this is in Italy, in America, UK, that they are looking at someone participating in up to 4 hours of therapy interventions a day. So that's physio, OT, speech and language therapist, etc. So, that intensive burst could be really intensive to really maximize outcomes. And then we're looking at from 3 months post HSCT onwards, so probably 3 months to 9 months, is this real, again, intense burst of this community rehabilitation. So still being aware of potential late effects and continuation of increasing the intensity of the rehab to achieve those physical outcomes, okay, and achieve those physical goals that have been set. Looking at returning to walk, returning to sport, returning to leisure activities. So the infection risk still remains high for the first 3 months and can be up to 6 months post-transplant. They reckon recovery can continue for the first couple of years, and it is important to optimize this period of time with a tailored and comprehensive rehab program. So even if you are 6 months post or a year post HSCT, you still have a real window of opportunity to keep training and look at what further gains can be made. And so physical activity has been shown to be more effective at reducing HSCT fatigue than pharmaceutical management. So making sure we're really exploring those. And remaining neurological recovery can continue in that first couple of years, as mentioned. So just recapping that the importance of a really individualized, because everyone with MS is different, but a really individualized rehabilitation program is needed at this 6 months prior, okay, to actually even starting HSCT, as well as that need to be monitored throughout your time in hospital, but then also making sure that you are aware of the commitment that's going to be required afterwards to get that body really back up to form and hopefully get you into the best possible position you can be in. So take home messages there. Hopefully I've pushed it enough that prehabilitation, okay, is absolutely vital. And as I say, David has been a bit of a gold standard first person to go through this process with, because of how fit and active he was prior to starting, and also how committed he's been through the program. And even, as I say, we're going into our next round of community rehab now to really maximize those outcomes. So we need to make sure there's been strong assessment data throughout and that is captured. So as soon as one of those outcome measures is dropping, that we can jump on it from a multidisciplinary team approach and ensure that we are onto that. And you really do need expert support. So if you are somewhere in the country where accessing a experienced neurophysio in MS is difficult, we as neurophysios, we are always more than happy to link up with whoever your local therapist is to make sure that you're getting the best. So neurorehabilitation is the form of active movement and it is essential for AHSCT success. So one without the other doesn't really work. So that is the two. So thank you very much. I think my questions are going to be coming afterwards because I think we're going to go straight on to Zoe. But if anyone wants to sign up for the MS Get a Head Start newsletter, then you can scan that QR code there. But as I say, all these handouts will be winging their way to Amanda. So I will wrap up there, Amanda, and hand back over to you.
Wonderful. Thank you so much, Gilly. That's so informative. We've already had some questions coming through, so we'll hold those to the end. Now we're going to hand over to Dr. Zoe Dyer, who's joining us all the way from France today. Very lucky she's there before she returns to Auckland as a clinical neurologist in July this year, which is exciting. Zoe is a trained clinical neurologist, having worked at Auckland and Wellington hospitals, and she is the recipient of the Neurological Foundation VJ Chapman Fellowship and has also received funding from the New Zealand Multiple Sclerosis Research Trust for her work over at St Vincent in Sydney on AHSCT. I'll hand over to Zoe now to tell us more about the exciting research which she has been focusing on.
Brilliant. Thank you very much, Amanda. Can you see my slides and hear me all right?
Yes, to both.
Perfect. So thank you. So I'm Zoe, and thank you so much to Multiple Sclerosis New Zealand for the opportunity to speak today and share some of our research. So I've called my talk Regulatory T Cells in MS, What We Know and Need to Learn About the Body's Natural Way of Stopping Immunity, so autoimmunity. And I'm sure a lot of you are thinking, I thought this talk was meant to be about bone marrow transplant and what on earth is a regulatory T cell. So this talk is about research into AHSCT and how we can make it better. It's specifically about regulatory T cells. And I know that unlike me, you're probably not all obsessives about regulatory T cells. So I'm going to keep that aspect of it fairly brief and talk more broadly about my experience at St Vincent, both on the clinical and research side, but also specifically about that particular research that I've been doing. As Amanda said, my background is clinical, so I trained in neurology in Auckland and Wellington hospitals, and I've recently been undertaking a fellowship at St Vincent's Hospital in Sydney. And the reason for choosing St Vincent's is that it has the largest and best established program for providing AHSCT for MS in Australia. And the team is amazing. This is a photo of me and some of the team here. And they've been supporters of New Zealand neurologists for many years. And as Dr. Pereira mentioned, me giving a lot of advice and been involved in the creation of the New Zealand AHSCT criteria. And thank you in particular to Dr. Jennifer Massey for being such an amazing mentor to me. So she's in the picture there, second left at the front. I think she's joining online today too, although I know that she's in the midst of kind of children time in Australia as well. So St Vincent's carries out AHSCT for MS as part of a phase 2 clinical trial. And the team also runs a very well-established translational research program, and that research program aims to understand how AHSCT works on a cellular level so that we can make it better. And again, as Amanda mentioned, so I ran my own research project under the umbrella of that research program, and the funding for the laboratory consumables and costs of that was from the MS Research Trust, so I'm very grateful for that. And I was also supported by the New Zealand Neurological Foundation. So I thought I'd start with some background. So this is about why I do research into Ahsct. And the reason for that is that our current treatment options for MS in general, are very good compared to what we used to have in the past, but there are major problems with them. So all of the medications that we call disease-modifying therapies for MS all treat inflammation, and they do that in a pretty broad spectrum way. So most of them either suppress the whole immune system, or Tysabri is a little bit different in that it stops all immune cells from getting into the brain and spinal cord. But they're all pretty broad brush treatments with large effects on the immune system. And as a consequence of that, as everyone on this call knows, they have side effects. And a separate problem is that we don't really have any treatment that specifically targets the progressive part of multiple sclerosis. So some medications such as Ocrevus have been shown to have some benefit for primary progressive MS, but the benefit's relatively small and probably only seen in a proportion of people who've got progressive MS. And there's a lot of work that needs to be done to improve those options. So I just had a slide and a quick recap about how Ahsct works. And David has already taken us through this today in a lot of detail. I thought that was really useful and really clear. So just to recap that, so Ahsct uses blood stem cells, and those blood stem cells include the immature white blood cells that go on to make all the different immune cells in the body. So when you undergo Ahsct, we collect those bone marrow stem cells from the blood. So that involves first giving medication that causes those cells to move from the bone marrow into the blood, and then we can collect those cells and store them in the freezer. So that was the mobilization that David talked about. And then heavy duty chemotherapy is given to remove all the existing immune cells. And then the stem cells that were collected earlier are put back in and regrow the immune system. And the reason that that is effective for MS is that the new immune system, which is regrown, isn't programmed to attack the brain and spinal cord. So we know that Ahsct is very effective in stopping the inflammatory part of multiple sclerosis, although there's a lot that we don't know about exactly how that works on a cellular level, which is the reason for continuing research. And again, Ahsct is a great treatment, but has limitations. And we've already really heard about that from all the speakers today. And again, I think David really summarized it when he said, Ahsct is not a cure. And unfortunately, that is a good summary of things. So, and again, as mentioned, Ahsct is very, effective in stopping the inflammatory part of MS. So that means relapses and new spots in MRI. But it's less effective at stopping the progressive part of MS. So people can experience progression of neurological disability after Ahsct, even if the relapses stop. In addition, some people do have relapses after Ahsct, although that's relatively uncommon. And then the other big problem, of course, as we've heard about in detail already, is that it requires reasonably high dose chemotherapy drugs, and there are significant side effects and risks from that. So I guess to summarize my experience in St Vincent's, I've met a lot of people who've had really excellent outcomes from Ahsct, and it's really exciting to meet people who might have had a transplant years in the past, and they've been living their life pretty normally and not having to take medication, and that is just awesome to see. But Ahsct does have problems and isn't the right treatment for everybody with MS. And so again, the reason for doing research into HSCT is to try and improve the treatment and make it better tolerated and more effective. So again, just to summarise, so some future goals of MS treatment include really trying to create a treatment which stops the immune system from attacking the brain and spinal cord without needing to shut the whole immune system down. And also to try and look towards treatments that are one-off treatments. So, you know, I think from talking to people with MS, that's something a lot of people want access to, you know, would really like a treatment that is a kind of one-off treatment and then you're done, you know, rather than needing to take medication on an ongoing basis. And to achieve those things, we need to know a lot more about how the immune system works and what happens in the immune system to cause MS. And we also need to understand the natural mechanisms that the immune system has to stop inflammation. So this is a picture from a neurological paper that was published last year, which summarizes what goes wrong in the immune system in MS. And I guess the overall idea is it's all pretty complicated. So the immune system's a huge network of different cells and molecules which interact with each other and, you know, interact with our own body and things like bugs and viruses. So this image I find all pretty complicated. So one I like better is this one. So this shows some of the different types of immune cell, and most immune cells are part of our own little army which attacks viruses and bacteria when they enter the body in order to fight infection. So examples are natural killer cells and cytotoxic T cells. So they're the ones that look like they're ready for a fight in the cartoon. And in most circumstances, this army is really useful to us, but sometimes the cells can go awry and attack our own body. So, as I said, in MS, these immune cells specifically attack the brain and spinal cord. And many of these cells are called T cells, and they're called T cells because they're made in the thymus gland, so it's T for thymus gland. And the thymus gland sits up in the neck in front of the windpipe. So, as I mentioned earlier, our research team is really interested in this guy here, the regulatory T cell. These are really important immune cells, which we all have naturally, and their job is to stop the rest of the immune system from attacking our own body cells. But, you know, as we know, they don't work perfectly all the time because sometimes people do experience immune-mediated medical conditions like multiple sclerosis. So in the specific research that I did, we wanted to learn more about these cells in MS and also more about their role in bone marrow transplant. And the big question going forward is whether we could somehow harness these cells in the treatment for MS. To say the short name for regulatory T cell is a Treg. You can see that on the policeman hat and badge here. So sometimes I'll probably just call them Tregs out of habit. So what do we know about regulatory T cells and multiple sclerosis? So there's been a lot of studies which show that these cells are different in people with MS compared to controls. It's probably important to say that MS probably isn't primarily caused by due to a problem with these cells. And the reason we know that is some very unlucky people are born with a genetic problem, which means they don't make these cells normally, and those people get, you know, horrible autoimmune disease that affects other organs, but they don't get anything that looks like MS. So the problem with these cells probably isn't the main issue in MS, but they might be a contributing factor, or they might change and become less potent as part of the inflammation that happens in MS. I think I mentioned this, but we're also interested in regulatory T cells because they're really important in bone marrow transplant. Okay. So the team at St Vincent's does a lot of work on regulatory T cells, and the specific research that I've been involved in aims to understand what happens to these cells over the course of bone marrow transplant for MS. So We wanted to understand what changes after transplant, and we also wanted to understand whether there are any differences in people who have relapses after transplant to people who don't. And I'm hoping to present the data from this research at the European MS meeting in October, which is the largest sort of MS conference in the world. One of the conditions of that is that I don't show any of the data anywhere else first, which I have to say is probably a good thing, because unless you're sort of an immunology obsessive, lots of graphs and data can become pretty dry. So I'm just going to stick to the high level ideas instead, and talk about how we did the research. So in the research we looked at, we were particularly interested in something called a T cell receptor. So T cells have T cell receptors. They're quite, unlike lots of things in immunology, that one's kind of named in a way that's quite straightforward. And these receptors have lots of different possible shapes, and the shape determines what the cells interact with. So when the shape of the receptor matches the shape of a protein on another cell, they interact with that cell. And we wanted to know more about those receptors because it tells us what the cells are interacting with. And it also lets us track those cells across time. So how do we actually do that? So St Vincent's collects blood samples from people who are undergoing transplant, and we collect them before people have a transplant for up to 10 years after a transplant. And we also have samples from the graft, which means that the blood stem cell product that's used in Ahsct. And after we receive them, we process those samples to separate out the white blood cells. And I learned to do that while I was at St Vincent's, which was a completely new experience for me as a clinician, because it involved using sort of proper science tools like centrifuges and fume hoods and pipetting. And the image on the left there is of the lab, the main lab room where we do that, and also run the main experiments. And then after collecting the cells, we store them in vats at minus 190 degrees Celsius. So that's a picture of me in the cryo storage room with the protective gear on. And then when it comes time to use those cells for research, we warm them up, which is something that I find pretty amazing. So you can actually freeze white blood cells like that for years and then warm them up again. And for the most part, they're sort of alive and working again. And then in my study, we use something called a flow cytometer, which separates out different types of cells. It's a very clever machine, which feels a little bit like magic when you're using it. So it uses fluorescent markers on the cell surface and then shines lasers at these cells as they go past in the fluid and separates them into different cell types. And then we took the cells and used tiny magnetic beads and a big magnet to release the RNA, so it's a type of genetic material out of them. And then we sent the RNA off to be sequenced, which means reading the genetic code. And specifically, we sequenced the genetic code for the T cell receptors that I mentioned earlier. So interesting part, what we found. So that process gave us a whole lot of information about what happens to these cells over the course of transplant. And one of the most important things we found is that it looks like there are some differences in people who respond well to transplant and that they don't have any relapses, and people who do have relapses after transplant. And the difference one of the differences seems to be that people who respond well to transplant have lots of new regulatory T cells in the blood after transplant. But people who have relapses or new MRI spots after the transplant don't have nearly as many new regulatory T cells. So that means they have more of the same ones that have actually survived the transplant and are actually old cells from before the transplant. And immune cells, just like people, get tired. So it seems likely that regulatory cells that have survived transplant are sort of old and tired and don't work as well as new ones. And perhaps that contributes to people having relapses after transplant. So, this is all very preliminary data. I think all people involved in science get really excited when they have, results like this and, want to, attribute a lot of meaning to them. And it's important that we recognise this sort of, preliminary results. But, it's really interesting because it's suggesting that perhaps there's something beneficial about having new regulatory cells in MS. And the reason, to me, why that's so interesting is, we wonder if we could use these regulatory cells in therapy. So one of the questions is, how do we make sure that people who undergo AHSCT, make lots of new regulatory cells, and that the haematologists at St Vincent have some ideas about how you might do that. And we wonder if that might improve the outcomes from transplant. We also wonder if there's a way to use these cells as a therapy outside the context of AHSCT. And overall, as I mentioned before, these cells are part of our body's natural way of stopping autoimmunity. So our natural way of stopping immune cells from attacking the body. So, we wonder if we could use these in a therapy. Could we make a therapy that's got fewer side effects? And this last thing to mention before I finish, there's also some really interesting work looking at these cells in neurodegeneration. So this work is in mice models, and we've got to be pretty careful with mice models because there's many examples where things that are found in mice don't translate very well to humans. But nevertheless, there's some interesting work in mice to suggest that these cells might have a role in remyelination and also in recovery from things like stroke and traumatic brain injury. So St Vincent is interested in looking at these cells and their potential role in progressive MS. And, as I mentioned before, one of the reasons that's important is because we don't have many options that directly target the progressive part of MS. So anything that sort of has promise of being a new treatment is really important that we look at. So I've just got a couple of slides to summarise. So, the current version of AHSCT is a great option for some people with MS, but does have limitations and side effects and isn't right for everyone. Research is really important because it can help us to improve AHSCT as well as other therapies for MS. And particularly important goals of research are, how do we stop the immune system from attacking the brain and spinal cord without needing to shut the whole system down? And how do we treat the progressive component of MS? So I'd like again to thank the Nzms Research Trust for the funding that was needed to do this research. Also to the research team. So I've had fantastic support at St Vincent's, particularly from Dr Massey and Dr Ian Sutton, who were my research supervisors, as well as the scientists who taught me the way around the lab, which was a new environment for me. And thank you to all the people who underwent transplant at St Vincent's who gave samples for research, because we couldn't do it without them. So I'll end there and see if there's any questions.
Thank you, Zoe. I'll just bring Gilly and David into the conversation as well, and we can look at what questions we have to cover. Thank you so much for that. It's really interesting to hear about the research that is going on, and St Vincent's are a great team and have got some amazing results out of there. We will start from where we have David. Were you able to work during the 6 months?
I was pretty fortunate that I'm self-employed and have a little bit of flexibility in my work, and so I wanted to give the treatment the sort of best chance, and so I took off the full month for the treatment while I was in hospital and didn't touch my computer, just forgot about work completely and focused on the treatment. So that was the whole of November I took off, and then by about midway through December I was starting to feel well enough and get my concentration back that I started to sort of do a bit of part-time work and answer emails and that sort of stuff. But I really sort of took the first month and a bit off, and then had a nice summer break and really didn't start back up full-time until the new year. And so I understand that's quite sort of variable for different people. And as I said, I sort of came through relatively unscathed without any complications and was able to get back into it relatively quickly, I thought.
Zoe and Gilly, have you had any experience of people and what they've been able to achieve during that time?
Yes, I mean, I guess something that's important about, MS and also in transplant is that everybody is completely unique. Certainly when people are going to undergo transplant in St Vincent's, they usually advise that they will need to take, at least a month off work during the transplant, often longer. It depends a little bit on what people do. And then, there's that period of months afterwards in which the immune system is down. So if possible, it's really important that people avoid, as much contact with other people as possible. And I guess, that is tricky because people are in different positions in terms of how feasible that is. And everyone is just a little bit different in terms of how quickly they bounce back. But, I think what David describes of his experience sounds pretty common. I don't think there'd be people who would bounce back and be at work much more quickly than David did. It's not something where you feel like getting up and going for a run as soon as you get out of hospital. It's just not what happens.
Yeah.
And I think, it's when you've just gone through this pretty big ordeal from a medical point of view to do something for your MS to put you in the best position, like it's you've got this window of opportunity from a rehab point of view, and as I say, to commit the time and the energy in in getting helping those neurological deficits as well as getting back to being strong and fit. I think it all depends on obviously individual situations, what your work may be, but if you've got an opportunity to take a few more months off or work a little bit more part-time or reduce whatever that stress and exposure is so that you can really focus on getting to that best possible outcomes you can, I think that's really valuable. But it's also where that role of that interdisciplinary or multidisciplinary team comes in, that your occupational therapist is going to be there supporting you, and and physios with your employer, or if you're self-employed, of okay, well, what can be adapted to make a home setup better to work from, or your job is you're a builder, and what does that look like to be back on the building site, and is there other other responsibilities you can do in that meantime. So definitely as I went up at that list up of that big team, like we don't expect you to kind of go this alone and work all of this out by yourself. That's where this big range of health professionals are there to help you to get that balance. But yeah, so from my point of view, the recommendation is if you've got some time and energy, invest that in the rehab to get well, and then work can come after as well.
I'm just going to skip to a question which kind of relates as kind of to where that's been. One of the questions, or two of the questions, were coming through about the rehabilitation particularly and costs. And obviously if AHSCT at the moment has been done in Auckland, and if people are requiring it from outside of Auckland and obviously come there for it, is the rehabilitation post-rehab protocol, will it be standardised and implemented, and also how will it be covered in terms of costs?
That's a great question, which we probably don't have really any answers on. As I say, for David to be the first person to go through this, as I say, I work in the private sector, and obviously David, we've had a working relationship for a long time, so hence why I really took on board to support David through this process of what the protocol should be. But actually connecting into the hospital physios at the time, they were very much didn't have the resources in the sense of that knowledge base in place. So I do think, this is a bit of a moving thing with Te Whara Ora. And I think, as I say, when they come through to say that they've got the resources from a haematology point of view to be able to deliver HSCT, I really hope that probably myself and Amanda together, probably as MS New Zealand, will also help, join the team to put forward what other things, should really come under a funded option. Unfortunately, most people will know with MS, you get very little funded access to rehab at the moment. So it will be, so I'm based in Auckland. There is many great neurological physios around the country, and you can find one local to you by going to Physio New Zealand website and popping in your area and looking for your local neurophysio. I am more than happy to connect and work with anyone. So as I mentioned, you might be much more rural and remote and might not have access to a neurophysio, but all of us post-COVID will do many things online, joint sessions, share protocols around. So that the costs are really variable. It will completely depend on, who you can access and what their fees are. But, as private therapists, we're all saddened by the fact that, all this rehab isn't available or funded. We'd love to live in an ideal world where it was. So if someone came to me and said, hey, I'm going to go for HSCT next year, and, I can only afford a few sessions, then that's my role as a physio, is to assess, really find out where they are and to give them a program that is going to put them in that best possible place leading up. And then, it's mostly making sure that you're getting those assessments and guidelines. So if you've got a lot of experience behind you about exercise and rehab, and you just need to be pointed in the right direction, then it can be quite nominal cost, not much. But if you've got some quite marked impairments that you really want to have this opportunity to improve, then you're going to have more intensity. So it's a bit of a long-winded, that it's all kind of very individual what may be costing.
Great. We seem to have just lost David off the call somehow. Hopefully he joins us back in a moment. We'll see which other questions we can look at while he hopefully joins us back. I'll just reduce that one down. If you have, Zoe, you might be able to answer this one. If you have AHSCT and then lesions and a relapse, could you start DMT again?
Yeah, it's a good question. So, yes, and that does sometimes happen. And I guess something I should say, it's pretty rare that people have relapses after AHSCT. It's not a common thing. And in fact, when I was doing my research study and we needed to find some people in the cohort of people at St Vincent's who had relapsed in order to be in that research study, they're pretty hard to find, actually, so it's not a common thing. But it does happen. And yes, sometimes those people start disease-modifying therapy again. One of the things we don't know is, even if you do end up needing to start therapy again, is it the case that you've still had a benefit from AHSCT? And it's possible that is the case, that actually, your immune system is still less active than it would have been, pre-transplant. And so you've still had a benefit even if you need to start therapy again. But that's really hard to know for sure. I've just written down too that to talk about the question about Crohn's from earlier. And I guess a couple of things I was going to say about that is that, so because AHSCT is an immune resetting treatment, it does have a role in other conditions that are caused by the immune system other than MS. And actually there is some research on AHSCT as a treatment for Crohn's, but I think it's less established than even the research we have for HSCT and MS. But the main issue, as Dr. Pereira mentioned, is that anything that causes a problem with the body is just something we need to think about in terms of the potential complications of therapy. So for Crohn's, that's things like getting infections that have come from the gut, for example. And that's where gastroenterologists and haematologists would be really important to think about those risks and how to manage them.
Great. And what about help in terms of guiding family members of the patient recommended through something like AHSCT? David, you might be able to talk about your experience from that and about the education that you had in your family.
Yeah, the team at the transplant unit at Auckland Hospital did a great job sort of walking me through that. And I think for us, so my wife was intimately involved in that education process. She attended all the sessions with the nurse specialist there. So I suppose.
Must be having some signal difficulties.
It's the modern world, isn't it?
Yeah. We'll try come back to that one. Does EDSS get better after AHSCT? And what is the highest EDSS that someone has had and gained improvement through after EDSS?
Oh gosh. So certainly EDSS can get better for some people after AHSCT. So there's a lot of the research trials show that a proportion of people do get an improvement. In terms of physical disability, I can't, the exact kind of numbers varies a little bit in terms of which study, but possibly as many as sort of 20% of people in some studies. I don't know if I could tell you for sure, in terms of all the published cases, that the person with the highest EDSS and who've improved. I guess just to talk about that, the reason why we're a little bit careful about AHSCT for people who have a high EDSS is just that the risks of having complications are higher. That's one of the main reasons we're just a little bit careful about that.
From clients that have gone over and got HSCT overseas, again, it kind of completely fits that criteria that Jennifer was talking about. Those that I've known who have sat between that 0 to 6 have often done, made some good improvements and, definitely maintained, but most people have come back and then have had that ability, often within that year to 18 months afterwards, make some good improvements. I have had several people who have gone over who have sat more around that EDSS 8 to 8.5. And I have to say that physically, there hasn't been any changes, and some of them have experienced things like maybe urinary improvements and some things like that, which obviously that can be quite quality of life changing. But unfortunately, it's those who have been at that higher scale around that 8, they're the ones who've also, we've had issues with the avascular necrosis and things like that. So, I definitely, from even my experience, that I feel like the criteria set in New Zealand seems to be definitely where the safest and the best outcomes are going to be achieved.
Yeah. Hi again, David. Did you want to see if you wanted to finish what you were talking about around the education for families?
I'm so sorry about that. I've switched to another computer now, so hopefully I don't have any troubles. Not a lot to add there. I just sort of stress that it is obviously a big impact on the whole family, not just me as the individual going through the treatment. And so I couldn't have done it without the support of obviously my wife taking the lion's share of the child rearing for the weeks and months, but then also the visitors I had over the time at hospital. While I couldn't see my kids, my parents and friends were able to come in, less risk of spreading infection, and that, I suppose, psychologically more than anything was a pretty crucial part of the whole thing. It would be a very daunting and isolating experience to do it all on your own.
Yeah. David, there's been 2 comments which kind of tie in together. One says, my family member went overseas for over 4 years ago for HSCT. There was no physio, as such, but they pay great emphasis on diet. For example, lettuce, vegetable type food items, rinsed in brown malt vinegar, no food, soft cheeses. And another person has also said, was there a particular diet you're following for good health while diagnosed with MS? You said that being young and good health helped recovery. So, and they're also glad that you managed to get treatment in New Zealand as well. Is there anything in terms of diet that you had to look at changing or implementing as part of your AHSCT?
Yeah, so I think there's sort of two parts to that question. One is some of the neutropenic diet that you need to follow post-treatment. So when you're in that immune suppressed state, you need to be incredibly careful of the risk of infection that you're introducing to your body, and food is one part of that. So while I was in hospital and for the months following, I basically had to cut out all of the stuff that could have some sort of bacterial risk. So it was, cooked food that was low risk of infection was the sort of diet following. So all the things like raw salads and soft cheeses and salamis and all that kind of stuff was out. Fruit that you could peel was okay, but anything like berries and that could harbour bacteria, that was all out. So that was somewhat restrictive immediately after treatment and for some weeks after. The second part of that question, I suppose, more generally around a healthy diet. I didn't follow any specific protocol or diet, and I think there's a bit of research around some of the different diets and how they impact MS. But I followed more just a general healthy diet. I gave up any alcohol for a few months prior and post treatment. I've been pretty good just on healthy veggies and lean meats and that sort of stuff, but no specific diet.
Yeah. David, and I think this is kind of the final question that's come through, and I realise we're over time. Do you feel there has been enough of a big difference to make the process worthwhile for you?
I think it's probably too early to answer that question, Amanda. What I would hope is when you ask me that in 5 years' time, I haven't had to be on any disease-modifying therapy for that whole time and haven't had any relapses. I think it's always going to be interesting to see how my current symptoms progress, and I don't think that's a failure necessarily of this treatment. That was never to stop that. It's the new symptoms that we'll never know whether I had them. Hopefully it's the absence of those symptoms and over the course of the rest of my life that is success for this. And so that's what I'm hoping for.
Wonderful. Does anyone else feel that they've got anything that they want to add before we close out the meeting that we've not covered? No.
Thank you very much for the opportunity, and I think well done, David. He's been a great first one off the ranks.
Yeah, I'd just like to say, obviously, I'm very lucky to have gone through this here in New Zealand and be the first, and I think a lot of that is the great work that MS New Zealand has done and the advocacy for the MS population here. So I'm incredibly grateful for all of that.
Thank you. We're proud to do it. Thank you so much, everyone. It was a pleasure being able to bring this to you tonight. Hopefully we were able to answer a lot of the questions that you might have had. You're always welcome to email us through info@msnz.org.nz if you have anything else, and we can look to see what we can respond to you with. We will have recorded this session, and it will be available on our website by the end of the week. And thank you again, everyone, Gilly, David, Zoe, and obviously Jennifer, who has had to leave us already, for your contributions tonight. Wonderful. Thank you so much.
Thank you.
Thanks, Amanda. Thanks, everyone.